My name is Michael Gerald. I'm an assistant professor of rehabilitation counseling here at Utah State University. And with me is Jennifer Hunsaker. Do you want to introduce yourself, Jen?
Yeah, I'm Jen Hunsaker. I am a clinical intern at the Sorensen Center at Utah State University.
Today, we're going to be talking about 6 vital truths of clinical supervision. We're going to do this a little differently insofar as we're not going to follow a strict PowerPoint per se. We are going to provide some framing information so that we can scaffold what we described today. But what we want to do primarily is we want to have a conversation between a supervisor and a supervisee about vital truths of clinical supervision. We've broken that down into 6 vital truths, 3 of which will come from the supervisee's perspective, and 3 of which will come from the supervisor's perspective. By way of professional introduction, I guess I should frame this in a slightly different way insofar as Jen is not only a clinical intern with the Sorensen Center's Clinical Rehabilitation Counseling Service Line, but more specifically, Jen has been my intern since last August. And so we're going to talk about our experiences as a supervisor and supervisee, things that we've both learned throughout the process, and try to provide some broader takeaways for the process of clinical supervision from a relational interpersonal perspective. So for today, we're going to review the reason why we engage in supervision in counselor education. We'll identify some gaps in the literature on supervision for master's level students in rehabilitation counseling. But more importantly, we're going to highlight 3 key aspects of counselor supervision from the supervisor's perspective, and then we'll highlight 3 key aspects of counselor supervision from a supervisee's perspective. And the exciting thing about this presentation, or at the least the thing that we were excited about when we pitched it, is these 3 key aspects, 6 total, are not necessarily ones that we pulled from the literature. These are things that Jen and I have been talking about over the course of the semester, or the last 2 semesters, and things that we've observed working together in a broader clinic in which there are fully licensed, provisionally licensed, and unlicensed student clinical interns, all of whom receive different types and levels of supervision. And so we want to talk about key takeaways that we have learned in working together this past year. To frame the conversation, though, I do think it's important to describe the difference between clinical and administrative supervision. Now, as many people know, quite often in practice, both of these will exist at the same time, meaning a clinical supervisor in a community-based private practice might also be an administrative supervisor at the same time. However, they are different roles, and so I wanted to quickly describe the difference between clinical and administrative supervision. In clinical supervision, you can think of clinical supervision as an intervention provided by a more senior member of a profession to a more junior colleague or colleagues who typically are members of the same profession. It is evaluative and hierarchical. It extends over time, and it has the dual purpose of enhancing supervisee growth and competence while protecting clients and the profession more broadly. The focus is on an individual supervisee and their relationships with their clients. Administrative supervision has similar functions to clinical supervision. However, they function under, or it functions, forgive me, under a business management model where the aim and priority is to keep an organization or agency functioning efficiently and effectively. Administrative supervision is involved in hiring, retention, termination, promotion, scheduling, and other administrative tasks required of a practice. Instead of clinical evaluation, they may engage in a performance appraisal or review. And again, quite often, supervisors and myself included will be engaged in both roles simultaneously with the same supervisee, such as in the example of working with a provisionally licensed supervisee who also might be hired full-time as a clinician. I might be providing the supervision as they work towards full licensure as a clinician, while at the same time being, for lack of a better word, their boss.
And what's interesting, we probably should have mentioned this at the outset, is that I also own a private practice. And so
Thank you.
I know for us that duality of clinical and administrative supervision happens to fall onto the same person most of the time. And so what's been really interesting is to see that separation in our situation, that it is more of a clinical function or clinical supervision function rather than that dual supervision.
Well, and that's because we've been able to fashion the CRC as primarily a teaching and learning clinic. And so we have tried to, as much as we can, minimize the role that administrative functions play in the work that I do day to day, teaching, supervising, even providing direct clinical services. So I appreciate you making that distinction, because in a private practice setting, certainly there are more administrative tasks that might be required to maintain a business, whereas we're just trying to maintain a teaching and learning clinic on a university campus. Now, these are just broadly some components of clinical supervision. Typically in clinical supervision, it's done between members of the same profession. Typically, it's evaluative and hierarchical, and typically it extends over time and is ongoing. I often describe to my supervisees that when they become fully licensed, they transition from a supervisee to a colleague in the field. And now we have a professional networking relationship rather than a supervisor, supervisee, mentor, mentee relationship. So what is the purpose of clinical supervision? Its primary purpose is to foster supervisee professional development. We'll talk later about professional identity development, and Jen will talk about that too when we talk about key aspects of supervision from the supervisee's perspective. In addition to professional development, which not only includes learning, skill development, et cetera, but it also includes professional identity development, the integration of the self into the profession of being a professional counselor, and then simultaneously, so these are not listed in any hierarchical order, but simultaneously, the supervisor is responsible for ensuring client welfare in the course of clinical supervision. And we've talked about this a lot in the context of our classes, but for supervisees, a lot of the angst that goes into learning as a clinician is at the same time that I am a learner of clinical counseling practice, I am also a provider. I'm also a practitioner. So that means that at the same time that I'm figuring things out, I am also providing services to real people. And so as the clinical supervisor, I have a dual role of maintaining both supervisee and client welfare at the same time, promoting growth in both at the same time while they are both learning, essentially. I do want to differentiate and define clinical supervision from other practices that might be carried out by a counselor or counselor educator. Teaching, which does occur in the context of supervision. Teaching alone, though, is typically driven by a set curriculum or protocol or accreditation standards, if you're thinking in terms of CACREP accreditation. Supervision is instead driven by the needs of the supervisee and their clients. So yes, I might be engaging in teaching with supervisees, but I wouldn't necessarily be doing so from a set curriculum. Having said that, we will talk later about a general model that we follow here at USU with respect to teaching and learning in a teaching and learning clinic. But by and large, the teaching is driven by the imminent needs of the supervisee in that moment. Counseling is not evaluative, and counseling clients can be more selective of their provider, whereas the therapeutic work that occurs in the context of the supervisory relationship is time limited, it's responsive to the needs of the supervisee, and it has to be related to supervision. So it's perfectly acceptable for supervisees to process distressing emotions or experiences insofar as it is related to the supervisory process. Just as an example, I've had supervisees who have had to process relationships with men and males in their lives as being a potential interrupting factor in the supervisory relationship between myself and them. Consultation, typically a relationship between equals and can be a one-time voluntary event. Consultation in the context of supervision, which is long-term, ongoing, and hierarchical, consultation might occur in a supervisory relationship, but it's only part of the ongoing teaching, learning, and support that comes from a clinical supervisor. This is just one example of a model of supervision. Some of you who are viewing this might be familiar with the integrated developmental model of supervision, or the IDM model, from Stoltenberg and McNeil. And Jen, unfortunately, you have had to hear a lot about this because this is my primary model of supervision that I utilize in the clinic. But it talks about 4 different levels of counselor development. So at the level one counselor, for the level one counselor, which typically is like a first year master's student. And just so everyone knows, the levels are loosely organized and aren't the most valid criteria for sure. So you can certainly have supervisees who are 1.5 or 2.5 as they go through, but typically a level one clinician would be your first year master's student in a counseling program. Very little experience, very little professional practice experience, very little exposure to the field. Typically these folks are highly motivated. They have a high need for structure, and they need to learn basic foundational counseling techniques. The level two counselor is experiencing a conflict between independence versus dependence. In this time period, clinicians are often trying to break away in some way, shape, or form from their counselor supervisor to become more independent in their practice. They may even feel that they are beyond supervision. I've certainly have had this experience, thankfully not with Jen, because Jen is a very humble counseling student, but I have had this experience with provisionally licensed clinicians where, hey, I got my master's, I did the training, I know what I'm doing, I just need you to sign my paper, I just need you to tell me about clients I maybe haven't seen before, but by and large, I generally have it. At the level three clinician, this would be someone who's developing more consistency in their approach, more consistent levels of motivation, and they are able to maintain a dual focus on the client and themselves. And level 3I, according to the model, very few counselors reach this stage, but these counselors have developed a personalized style and approach, and they have broadened their skill set. This is a more thorough overview of the IDM model of supervision, specifically the 4 levels of counselor development. As you can see, there's motivation, autonomy, and awareness levels for all of them. Just as a couple of things that I wanted to point out, motivation fluctuates between highly confident to unconfident in level 2. And one of the things that I'll describe to clinicians in training is motivation does continue to fluctuate, I would argue, throughout the counselor's career. However, those fluctuations tend to be less drastic. Whereas for the level 1 and level 2 clinician, they might be experiencing changes in motivation such that one day I feel like I'm great, and as I've often joked with Jen, I'm Carl Rogers reincarnate, and then other days I might feel like I don't belong in this field at all, and all I'm doing is hurting people because of my lack of skill. Whereas at the level 3, just as an example, motivation is more consistent, there's less self-doubt, much more self-awareness. I often describe to clinicians at the level 1 and level 2 that there's a really uncomfortable truth, and that is, even at level 2, most counselors in training are more self-focused. What am I doing in the context of the counseling relationship? What did I do wrong or do right, etc. Ultimately, though, what we are trying to develop with our clinicians are 3 things: comfort, confidence, and competence. Competence referring to skills, comfort referring to my emotional well-being, to my sense of self, my sense of belongingness, and then confidence, my level of self-efficacy, my belief in my abilities as a clinician. Now, quickly, I only want to define professional identity. I don't want to spend too much time on it, but professional identity is the view of self as a professional plus competence as a professional, resulting in congruence between personal worldview and professional view. Jen will talk about this a little bit later, but one of the things that I find as a clinical supervisor is it doesn't really do a lot of good to try to indoctrinate students into the field to adopt the professional identity that they think they need to have as a counselor, what a therapist is, what a therapist does. Instead, it's much more important to help clinicians in training maintain their sense of self while incorporating the parts of self that are congruent with the field into their broader professional identity. Just as an example, we talk about this all the time. For my clinicians who are naturally empathic and caring, we want them to maintain that part of themselves as part of their overall professional identity. And then lastly, for my section at least, I guess I should say that, becoming an ethical professional, according to Amatrano 2014, requires 4 steps. Marginalization occurs when there's low identification with both my own and the values of the profession that I'm entering. So basically, if we think about the levels for the IDM model, the level 1 counselor might have limited understanding of their own cultural background, their own ideas and beliefs about health and well-being, therapy in general, their own personal values, and also limited knowledge about the values, culture of the field. Now, eventually though, counselors in training will move to separation, where they'll have a well-developed personal moral sense, but they may not identify with the values of the profession. They may have difficulty adopting the values of the profession. I run into this with counselors in training when it comes to the concept, and Jen and I have talked about this, of acceptance, where some clinicians will say, well, certain things are unacceptable to me. Maybe I can't adopt the accepting disposition of the 2024 counselor because of these things that are a part of me. So again, that's a strong identification with self, limited or less identification with the field. I then will see students engage in what's called assimilation, where there will be a complete adoption of the new culture's values while discarding the values of the culture of origin. This is where I'll hear counselors in training say, when I go to work, I am different. I leave myself at the door. I leave my own stuff at home. And there's that separation between self, who I am as a person, and who I am as a therapist. And ultimately, where we want counselors in training to get to is integration, where I have adopted the profession's values while retaining important aspects of my own personal values. Again, going back to my example, for me personally, I have a strong value of service to others. Well, I would want to keep that as a clinical mental health counselor, as a rehabilitation counselor. I would want to maintain that personal value because it is congruent with the work that we do in the field.
And interestingly enough, integration is the goal, our goal as clinical rehab counselors, the integration of that identity for persons with chronic illness and disability. And so the fact that this mirrors exactly what we're trying to do as professionals, it makes a whole lot of sense. I mean, it's not a completely separate entity to engage in counselor supervision.
Well, and you and I have talked about that a lot, Jen. It's part of what we've tried to construct with respect to our model of supervision such that it mirrors what we're doing in counseling. Therefore, our supervision, at least the hope, is that it's always modeling what we're looking for from our clinicians. Similar with being personally present, with being empathic, with being accepting. We want to do that in supervision as well. So to model that for when our clinicians are providing services to their clients. Excellent point. Okay, Jen, talk to us about ineffective versus effective counselor supervision.
That's no pressure sitting right next to the guy that's providing me clinical supervision. I jest. But really, the more effective approaches to clinical supervision have to do with, first and foremost, having a vision for what clinical supervision looks like. We've talked extensively about mission, vision, model. My previous life in organizational development, that was really the crux of what we did, was we focused on what is your vision and how are you going to implement that? And so first of all, it's important to ask yourself as a supervisor, what is my vision for myself as a supervisor and as for my supervisees as I go forward? It has to be a balance between goals and processes. We've talked just a little bit ago about the idea about administrative supervision. And in those task, process-oriented supervision tasks. I already said tasks twice, but that's okay. But in those processes, we'll edit that in post. But in balancing goals and processes, I think we all come into this profession with professional development goals. In fact, that's a criteria for our internship coursework. And so there has to be, and you can't really adopt one without the other. You have to have some process and some goal. There has to be structure and consistency. I've seen this too many times, supervisors who are themselves practitioners who are entirely too busy for their supervisees. And so having a structure and a consistency to when you provide individual supervision, in our case, when we provide group supervision, we have a standing group supervision time, just having that structure and that consistency of what that looks like.
Also, having an emphasis on and the prioritization of the supervisory relationship. I think that's been one of the most surprising things for me as an intern is that supervisory relationship and how that's developed. I mean, I joke, but like how many times have I cried in your office? But in that process of developing myself as a counselor, there has to be a relationship there that mirrors what you would typically find in a counseling relationship. There needs to be an emphasis on supervisee growth and development, and we'll talk more about this in a little bit, about what that looks like and how you do that in a practical sort of way. And then also an emphasis on the supervisee's wellness. I know that in our setting, in the CRC, we have supervisees who have dealt with an enormous amount of personal issues, loss, divorce, abuse, chronic illness, everything under the sun. And so we have to remember that we're first people and we are people with complex lives. And so prioritizing that wellness really will pay dividends in the long run. And then finally, demonstrating care and regard. Again, we are counselors. And if we cannot demonstrate care and regard in a supervisory relationship, then really, how are we going to expect our interns to do the like for our clients?
How can we expect them to care for others if they have not also been cared for?
Exactly.
Which reminds me of the conversations we've had about the ethics of care.
Mm-hmm.
We care because we have been cared for. Theoretically, we're trying to pass that down in the supervisory relationship.
Well, that we have so many conversations about burnout, but none of those conversations ever relate back to care.
Right.
Like we talk about hours that you work and the number of clients, your caseload and caseload management. We never actually connect the two. That burnout really is related to a lack of care and regard for clinicians.
That's an excellent point. You ready to talk about less effective
Let's
approaches to supervision?
Let's go. Of course, there's the no model. Sometimes it happens that a supervisor is someone with seniority or happens to be adept as a counselor, but lack the training in clinical supervision. I call this the Michael Scott principle. So,
I was really curious where you were going to go.
Right. It's the Michael Scott principle. Who is Michael Scott? I'm famous for The Office, is a fantastic salesperson and a really, really terrible boss.
Yep.
And so this is what happens a lot of times, that you have a supervisor who is thrust into a supervisory role simply because it's convenient or they have the credentials, but not necessarily because they have the know-how or the desire. You have the expert model. Oh yeah, go ahead.
The other thing I used to see when I did nonprofit work and also work for state agencies, who's been there the longest?
Right.
So it's like level of years there, you eventually will just move up no matter what, regardless of supervisory aptitude.
Right, absolutely. Well, and so often that's what happens, especially in agencies where caseload numbers are high.
Yes.
Where that's kind of the default, that people have a tendency to say, oh, well, you've been here the longest, like you said. You have the expert model where the supervisor is the holder of all the information and the intern is a learner or a blank slate. This is the Sherpa model. They come to you, the guru on the top of the mountain, please pour into me all of your knowledge. When in actuality, it really kind of misses the mark as far as what can develop later on. When you're talking about colleague relationships, eventually you're going to have to transfer into a more colleague network oriented relationship. How do you do that with an expert model?
Right. If I've only ever been a teacher.
Right.
Right.
Then there's the one size fits all model. We love things that we can just copy and paste. Love things you can copy and paste. Unfortunately, training supervisees and interns is not one of those things. Everybody comes to you with a different level of experience, a different level of competence, and it really is important to differentiate that internship supervisee relationship based on what that person needs. And then finally, the supervisee as patient. Some clinical supervisors love to approach supervision as they would with their clients and think of their development in terms of a diagnosis. How do I fix you so that you can become a competent professional?
And historically, some fields have even adopted that, where some fields have required students to attend therapy as part of their training, which would be much more like this model. And to be fair, that would certainly be emphasizing internal growth and development just by way of the counseling process, not the supervisory process.
But man, that's a tricky line to walk.
Very much so. Yeah, which is why it's not something that I would ever force someone to do.
Oh, and then finally, there's some There's some issues that can interfere with supervision. On the part of the supervisee, you might run up against resistance. You've said this before, that you had a supervisee one time tell you, "I don't want to learn anything."
Y- to quote it exactly,
Oh.
I don't need you to teach me
That's what it
anything.
is.
That's what it was.
That's what
Yep.
it is. I don't need
Yep.
you to teach me anything. And so you can run up against some of that resistance, especially when there's a lack of care and regard in that relationship.
And to be fair, some of the resistance, and I don't know if you've ever felt this, I don't feel like we've ever gone over this with you. Because there is such a strong desire among supervisees and counselors in training to perform well, because again, they're learners and performers, practitioners at the same time. Some of the resistance can come from, I'm getting direct feedback that what I'm doing is working. I don't want to make changes.
Right.
So I did a scaling activity in the beginning of session. Clients said 8 for anxiety. When they left, it was a 2. And if I'm telling them, you should go deeper, or you weren't very present, or blah, blah, they'll say, well, yeah, but
Right.
it worked. And so some of the resistance not only comes from potentially low self-confidence, but it can also come from the need for immediate direct feedback that what I'm doing is working. You're telling me to do something different.
Absolutely. Of course, we never experienced that ever. It's fine. There's also the risk of attachment to a supervisor. There's shame, guilt, low self-esteem, the need to feel and appear competent. I know for me, coming in that very first day, having that very first client and thinking, I've got to know what I'm doing.
Right.
And I have to appear like I know what I'm doing, not just for the client's sake, but in terms of supervision. Like I can't say I don't know in this situation. And there's a tremendous amount of pressure on the part of the supervisee to do well in those situations. Like you said, they're a learner, they're a clinician, they're a supervisee, all at the same time, and they have a lot of different hats they need to wear.
I do want to go back to the need to feel and appear competent. Do you think that's why you liked CBT at first?
Oh, absolutely. Yeah, because you can be objectively good at CBT.
And you can quickly show that you know what you're talking about because you're doing psychoed.
Right, exactly.
Interesting.
Interesting.
Yeah.
Little gee whiz. It's fun. And then ultimately, there are supervisor issues that also interfere with this whole process. Attachment style, interpersonal power. There is something to be said about, I need you to do this, and I need you to do this now. And please don't ask questions, and I don't have time to explain this, especially in agencies that are extremely busy.
Or I need you to listen to me because I'm in charge.
Right.
Right.
Right. Absolutely. And then also it depends on what the supervisor's definitions of counseling, therapy, and supervision are. We talk about this a lot at Utah State. What is counseling? What is therapy? What does a therapist do? And all of these philosophical questions. We have lots and lots of conversations about this just to kind of define where everybody's at, what everybody needs, how everybody needs to move forward. And then ultimately, the supervisor's role within the agency can have an impact on that. Like we talked in the beginning, if you're both their boss, their administrator, and their clinical supervisor, how do you differentiate that? And when it comes time to make hiring decisions, how do you differentiate those two things?
Right. Right. Can the supervisee be that open in the context of supervision if that could also potentially be part of their evaluation with respect to employment?
Absolutely.
I did want to point out, I have run into issues with the definition of counseling, therapy, and supervision, where my personal definition of counseling and psychotherapy is much more of a psychotherapy lean, meaning looking for personality change and reconstruction over time through the context of a relational approach. And then I work with supervisees who think counseling is about solving individual problems. And that doesn't necessarily mean that the supervisee and I don't get along or can't get along, but we are operating in the context of supervision from two very different definitions of counseling generally. So, time for our 6 vital truths. First, I'll start. Counselor growth and development is intensely personal. We talked about that earlier, where I am a firm believer that the development of a counselor is, I would argue, mostly personal development, which means that in order for someone to become a good clinician, an effective clinician, a clinician that lasts in the field and doesn't burn out, much of the development is internal. You can learn as many, poor Jen has heard me say this 50 times now. You can learn as many skills as you want, but it cannot cover issues related to personality. It cannot cover questions or doubts that one has about belongingness in the field. And so much of supervision is about personal internal growth, congruence, to borrow from Carl Rogers and person-centered, between who I am and what I believe is expected of a clinician. Now, having said that, then, that also means that counselor growth and development is intensely interpersonal. It also means that in the context of supervision, much of the growth that's going to take place, at least I would say this is our opinion based on our experience, is based on the nature of the relationship between supervisor and supervisee. Much of, and I'll just pick on you, Jen, but much of Jen's growth has been due to her own reading, her own learning, and exploring the things that she's learning with me in the context of what I would hope would be an open supervisory relationship whereby most topics are perfectly reasonable and related and relevant to the work that we're doing. And in doing so, Jen has been able to explore not only the things that she is learning, but more importantly, perhaps the things that she was learning about herself in the context of that supervisory relationship.
Well, and I think it's really kind of important, because I think some people will look at this and say, well, wait a second, but how do I get them in to see clients, and what role does that play? And I've got to get them up to speed, and this is meant to be, how do we get them to be functioning practitioners? But I would argue that this is actually the most important part of supervision, because there's going to be no other time in a person and a clinician's life where they will have this kind of a relationship and this kind of an opportunity to do that personal and interpersonal development. After you graduate, and even if you're provisionally licensed, you're going to largely be on your own. And so at that point, when supervision continues, that point you need to worry more about how do we increase your caseload? What kind of caseload management things do we need to do? I think at that point, that's when that's more appropriate. But there's never going to be an opportunity like this.
Mm-hmm. No, and what's interesting is, and I want to be careful not to be critical of other programs, but some programs that you and I are familiar with, their internship classes are much more about talking about clients and then identifying specific interventions for specific presenting problems or diagnoses. And the problem with those types of courses that don't focus on internal growth and development, the clinicians might now have a bunch of techniques, but they don't necessarily have confidence to be able to administer them effectively across clients. They don't necessarily have any self-understanding for why they are, persistently diagnosing clients with the same diagnosis, or persistently going to the same interventions, or not seeing growth in their clients, or are biased towards certain clients with certain presenting problems. So to your point, I think that a big part of what has made it so that this could be our focus is, and you'll recognize this from your theory, trusting the supervisee has the foundational skills to function effectively. I think, and I'll talk later about this, but I think that's why I put such a heavy emphasis on the dispositional or characterological traits that we look for in our clinicians: openness, integrity, humility, etc. Because, honestly, if you can sit in a room with someone for 50 minutes and simply listen, you and I both know that can be incredibly effective therapy. And then in the context of, again, hopefully a healing supervisory relationship, a growth promoting supervisory relationship, somebody will over time start to incorporate more theory and more technique into what they do.
Well, there's a certain amount of safety to do that in that kind of an open and supportive relationship.
Tell me what you mean.
So for instance, I feel like, and we'll get to this in a little bit when we talk about counseling or theoretical orientation. But I think there's a certain amount, when you can sit there with your supervisor and openly communicate, not just about how a session goes, but how you feel about how a session goes, then there's safety to be able to more fully integrate your theoretical orientation or new techniques or yourself into a session, because you don't feel like you have to perform at a certain level in order to be a certain type of clinician in those environments.
I think that's an excellent point. And that increased self-understanding, I think, also helps with, let's be frank, ethical practice.
Absolutely.
Because then I am much more aware of my own limits, my own boundaries, my own biases. That means that if I have enough self-awareness of my needs, then my self-disclosures are probably going to be more purposeful, more intentional, and less about meeting an unmet need that I'm not even aware of. Okay, Jen, you're up.
Okay, this is probably my favorite point, is that interns need space and guidance to develop a theoretical orientation. And we alluded to this a little while ago. I came into my internship fully knowing that I was going to be a killer CBT therapist. I fully knew that.
To be fair.
Yeah.
You probably could have been.
I probably could have been. Because I'm amazing. But I came into internship that was what I was going to do. I was confident in that theory. I was confident in the techniques. I had done a whole summer seminar on it. Like, I was ready, and I felt very prepared to be a CBT therapist. But what happened was it wasn't 2 weeks into the process. It was very, very quick that you, in individual supervision, you sat down, you looked at me and you said, I don't think you're a CBT therapist. And honestly, I was shook, because how can I, wait a second, like, all of the things I know about myself, how could I possibly not do CBT in this setting? But what happened was that started a whole process over the course of the last 7 months to be able to go, well, what am I then? And who am I then? And what theoretical orientation fits better with the kind of practice that I want to do in the future, and ultimately landing in person-centered land. And it's been a freeing experience, but it's been a very difficult one too. So to have the freedom and the space and the guidance to develop that kind of a theoretical orientation was absolutely vital to my growth as a clinician. And I think it has paid dividends, not just for me, but for my clients as well.
Because if I'm understanding correctly, you are in your sessions more fully present because you are not as worried about what you're doing.
Exactly. Which is what you just mentioned a little bit ago, was this idea that when you can move up to a level 3 clinician, it's less about you and more about what's happening in session. You can be simultaneously aware of you and them. And that's what that theoretical orientation has given me. Now, to be fair, Utah State has a heavy emphasis on developing theoretical orientation, right. Not necessarily a theoretical eclecticism, but to find and align with a particular theoretical orientation, and then to add technique on top of that if that theoretical orientation dictates.
Excellent point. And I think one thing I wanted to say, though, just to walk through how that all happened, just for folks who might be watching this, I hope it comes across, and I hope it came across to you, Jen, that me saying you didn't sound like a CBT practitioner wasn't me disallowing you from exploring. Absolutely. And instead, it just came about because of your description, and that was the openness of our supervision sessions, which one of the things I often will tell supervisors in training is supervision mirrors the counseling process. Actually, a better term is parallels the counseling process. So in the context of getting to know you, in the context of asking you those questions of, I know you don't like this, but to what end? Mm-hmm. I'm going to do this. Okay, to what end? Why? And your responses just weren't really congruent with CBT. On the one hand, as you described earlier, you were very comfortable in that role of expert, in that role of teacher, but at the same time, from a personal standpoint, it didn't really fit with how you wanted to relate to and connect with others. Mm-hmm. And so as we talked about it, all I did was say that it sounds like this. And as soon as you got into person-centered, it seemed like it fit like a glove.
Absolutely. Well, but that also required you to have a tremendous knowledge of counseling theory. To be able to identify it and go, okay, I know what you're saying, but I think this is what could potentially fit better. And so I think what happens when you get into the field, when you actually get into treating and into private practice or to your state agents or to whatever agency you're working in, you have a tendency to forget your theory. Right. You get so busy in the doing of the thing that you forget the theory behind why you're doing the thing. And so to that point, you had to have enough of an understanding of counseling theory to be able to look at it and go, this sounds a little more like this rather than like this. And it was definitely not a disallowing of, if I had said, nope, I'm going to be a CBT therapist, I think you would have been like, okay.
Well, and I think you've had this experience. That's why I love those questions of why do people suffer and why do people change, starting with our colloquial, anecdotal ideas of why that is. You know, I use this example in class of somebody saying one time at a presentation, well, it's about your attitude. Well, that would seem to be cognitive in nature. So you'd be more in the pragmatic school of thought. But I like doing that because then if we can find a theory that fits with a supervisee or student's worldview, research shows that my belief in my approach contributes to therapy outcomes. And just as you're describing, then in session, you get to just be you, and you are not as worried about what you are doing. Now, obviously, and you've already alluded to this, that doesn't mean we're talking about ourselves or engaging in unethical self-disclosure. It just means that I'm not constantly evaluating what I'm doing in the midst of a session. And I think that that dovetails neatly into my next point, which is if we want, and I know we preach this in all of our programs, reflective practice. We want our clinicians to be reflective about the work that they do, to do introspective work after a day's work to find out what worked, what didn't, what they felt, what they didn't feel, where they might have found barriers or what have you, internal barriers. But reflective practice, fostering reflective practice requires reflective supervision. So as Jen was describing, when Jen and I meet for supervision, which we're going to be able to do for the next few years too, which is pretty cool. When Jen and I meet for supervision, I don't ask Jen what she does. I don't ask Jen, what she's going to do. I don't tell Jen to try certain techniques or ask her if she has tried certain techniques. Instead, and I hope that this comes across, I am more inclined to ask, why did you do that? And I know that that question can come across as challenging just hearing that outwardly, but really what I'm trying to develop is intentionality by compelling an intern, a provisionally licensed practitioner, to give me a clinical rationale for why they're doing what they're doing, but also to describe their internal experience and process as the session is going on, as you're working with a client. So maybe it's something like, the client seemed really hurt. It seemed like they needed to be taken care of. And the mama bear in me came out because I wanted to care for them. That was why I was offering reassurance. So I don't, as the supervisor, need to punish that happened or that the counselor in training stepped out of that role momentarily. Instead, as part of fostering reflective practice, I simply want to make that known.
Right.
I want to bring that to present awareness that that's why I did what I did.
And what's interesting is that the more you engage in a supervisory experience like that, the more, once you see it, you can't unsee it. So when things like that happen in session, it's almost like you have a second level of awareness of, oh yeah, why did I do that?
Yeah.
And it's not, it doesn't necessarily mean that you have to stop the session and process right then, but you can log it away and go, oh, why did I react the way that I reacted in that context?
And you've seen it in observing some of my sessions. I still have to do that, where maybe the first 20 minutes I get on something and I think this is where we're going, and I start driving the client in a certain direction. Even I will have to do, a momentary reflection in my own mind to say, why am I doing this? What am I thinking? And that might compel me to either utilize a self-disclosure, a Rogerian self-disclosure of I'm confused, or I thought we were talking about blank, or to simply go back to my basic listening skills and to stay with the client, to basically regain presence in the session. Now, to that end, though, have you found reflective practice in the context of supervision to be frustrating at all? Because it doesn't always include answers.
No. And I think part of that, frustrating in so much that there are sometimes I just simply don't know why. I simply don't have an answer for why I do certain things or why I think certain ways or why I simply don't have answers. And so it requires another level of introspection outside of individual supervision to come to some sort of a conclusion. But in terms of frustration, I would never say it was a frustration. It was just simply, well, shoot, now I gotta think more on why. But what's happened over time, and especially as I've become more aware of what my theoretical orientation is, I have those answers. I know why, and I know why it's important relative to what I'm trying to accomplish or not accomplish, as the case may be.
Well, wait, what made it okay being a first-time mental health counselor to not receive direct guidance?
I think a lot of it was that I was never expected to have all the answers in individual supervision either. Like it was okay for me to not know certain things. I mean, you're an instructor in our program, and so for me to come in and say, I don't know. I mean, there's a certain level at first. There's a certain level of, hey, guess what? You didn't teach me this, but there was. I had the ability to say, I don't know, and I will find out in that individual supervision. And so it became okay for that to happen even in a session to go, I don't know why I'm reacting to this, but I'm going to go, like afterwards, I've got to go and process this, or I've got to think about this, or I've got to talk about this outside of session.
You know, it's interesting that you say that because I think for me, a lot of that requires trust in the supervisee.
Absolutely.
That I don't need an answer right now. I don't need to correct this right now. Or maybe there's this one part that we'll work on. We're going to leave the rest.
Right.
And we talk a lot in our program about the counseling lifespan. So the lifespan approach to a counseling relationship with a client, whereby not every session matters insofar as the entirety of the process is what matters and how that individual session contributes to that overall process. And the same thing happens in supervision. Mm-hmm. There might be something that I see that I think, oh, you know, I really wish Jen would do this, or I wish Jen would work on this more. But in the broader context, it could very well be that we can let that go. It'll either develop on its own or we'll get back to it because there's something more pressing we need to work on.
Absolutely. But like you said, it takes a tremendous amount of trust, and it also takes a lot of it takes a relationship at the outset of that.
That's a great point.
Supervisor-supervisee relationship. That coming into it and being willing to spend some time to develop a trusting relationship with another person, not necessarily as I have to do this in order for you to get licensed and so we can then put you into the system, but I need to be your mentor. I need to be the person that you come to with questions, and I need to be a safe space in order for you to fall down sometimes and be able to get back up.
Mm-hmm. You ready?
Yeah, let's go. For supervisees, I think this is probably, we had this conversation in internship 1 at the beginning of the year about imposter syndrome. Every supervisee comes in with a certain amount of imposter syndrome. They're like, yeah, I've been in didactic work, but like, you're really going to trust me with these other people? Like, are you really going to put me in a situation? And so supervisees, they absolutely need to know that confidence comes from supported internal development. I think that we have a tendency to rely on skill to develop confidence. If I can be certified in these skills, if I can go to these trainings, if I can have this continuing education, then I will have more confidence. And for me, at least coming into supervision, having done a lot of work in CPT, that's where my confidence was coming from. I had this skill and I knew how to do it. And there was absolutely no way that you were going to deter me from it. And so, but really confidence actually comes from that supported internal development, like we talked at the very beginning. Like that counselor growth is an intensely personal and interpersonal experience. Like I look at my experience over the course of the last 7 months to be able to, and the amount of internal work that had to happen as a result of my internship experience. And I'm so grateful that I had a chance to be in an environment where I had the space to do that. I did not have a huge caseload that I was trying to manage on top of having a personal and interpersonal growth experience. But ultimately, my confidence as a practitioner, my confidence as an instructor, my confidence as a future supervisor comes from that internal growth, not from any skill development.
I think that's an excellent point. And I agree with you wholeheartedly, mostly because we did this together.
Oh, yeah.
But also because, going back to the last point about reflective practice, if all I were doing with a supervisee were teaching skills, oh, okay, you've got a client with this, try this. We talk a lot in our clinic about implicit versus explicit communication. And the question becomes, what am I communicating to the supervisee if I'm constantly giving you new things to try? I am conveying that you need to be doing something. That whatever is not happening, whatever you're feeling, can be overcome by doing more, by more training. And it puts the problem outside of the supervisee. It cuts off that internal reflective practice. And it doesn't do anything to build internal confidence, because it's basically saying, well, the reason you're not doing well is because you don't know enough.
Right. And if you're feeling less than confident, it's actually your fault.
Great point.
There's a certain amount of fault that comes with, oh, well, have you tried this? It's like, well, you clearly you don't know enough, and clearly you haven't done enough, and so
The client would be doing well.
right, if
Yeah.
you only did, or if you only considered. And I love this in context of the stage model that you were talking about earlier, especially because there's a lot of firsts that happen when you come into the profession.
Yes.
You have your first client that comes in with severe and persistent mental illness. You have your first client who's experiencing suicidal ideation, or who passes away, or who, depending on your clinical setting, there's a lot of firsts that happen where if your confidence is in your skill and those things happen anyway, then of course your confidence is going to be shaken as a first-time clinician.
Because I will have the perception that this new client with a new problem is outside of my skill set.
Mm-hmm. Or if bad things happen, it's because I didn't do enough.
I'm smirking because that's something you and I talk about a lot. And that's the perception that supervisees, counselors in training have, that if I just did more, I would be better. If I knew more, I would be better. This is my last one. But this is important to me personally. The core therapeutic conditions, thinking about Rogers' core conditions, are not just for counseling. And what I mean by that is the therapeutic conditions as laid out by Rogers. And by the way, I know that these are all too familiar to you, Jen, with Jen being a person-centered therapist. But for those who aren't as familiar, I'll just quickly recap them. But Rogers actually technically had 6 core conditions, 3 of which are more related to the overall setting and interaction. Client is in a state of incongruence, that kind of thing. So I'll just focus on the 3 core conditions that need to be not only demonstrated and felt within the clinician, but also received, in this case, by the supervisee or counseling learner. Accurate empathy, empathic understanding, unconditional positive regard, warmth, acceptance, and then lastly, congruence with the relationship, authenticity, genuineness. The supervisor is who they say they are, and they are present in the moment. I share this because one of the things that I find as I work with students who are being supervised by others, or even working with provisionally licensed persons who are experiencing supervision with others, maybe I'm helping supplement their hours, or maybe they've been referred to me because a supervisor retired or left a practice, something like that. I find a weird disconnect where supervisors and counselor educators don't always demonstrate the core conditions, and yet expect clinicians in training to be able to do so, and might even admonish a counselor in training or a counseling student for not demonstrating the core conditions. And so for me personally, I have found, Jen, and I really, really hope you have experienced these in the context of our meetings, that telling my students, telling my clinicians in training, telling even just the clinicians I supervise, even at an administrative level, to demonstrate unconditional positive regard with their clients, if they are not feeling that from me, it's empty. Right. It's hollow. It doesn't ring true. And so I think for me, one of the things that I personally have learned and have certainly seen a lot of success with is that a lot of the internal growth and confidence that you were describing a moment ago comes from a supervisory relationship that isn't necessarily any different foundationally than a counseling relationship, meaning the supervisory relationship still has the core conditions present and hopefully felt, received, perceived by the supervisee.
Well, and even this has even been validated empirically to a certain extent. Like we have 200 counseling theories, or however many counseling theories.
The number in
It varies.
Yeah,
But it always comes back to the fact that there has to be a caring and accepting other. It always comes back to that.
Yep.
And so to say that a supervisory relationship has to be devoid of the very things that are foundational to change in any human relationship. I'm sorry, I'm getting on my high horse about Carl Rogers right now, but to say that needs to be separate from that. I think that it goes back to this whole idea that supervision is supposed to be administrative and not clinical.
Right.
Because how can you have those core conditions if you're going to have to fire a person? Or how can you have those core conditions if you have to do performance evaluation? It's a much more difficult process to do that than it is to do it in a clinical context.
Well, you and I talk about this all the time. And I in some respects, I'll pitch this openly, although it is somewhat a leading question. Am I demonstrating unconditional positive regard and acceptance if I'm constantly correcting
Exactly.
my clinician? If
Exactly.
I'm constantly, whenever you share something, saying, have you tried blank? It then creates, I have found, insecurity within the counselor in training. It also stunts growth and development because as opposed to growing and integrating self into their professional identity, the integration that's occurring is their self with who they think I want them to be, which per the theory would actually lead to incongruence, greater insecurity, anxiety, etc.
Absolutely. And then ultimately, we love feedback. Supervisees love feedback. Now we have in the context of our instructional process, we have feedback built in. We record videos. We offer feedback to one another in class. We receive feedback from our clinical supervisors, and our instructor, which happens to be just you for me. But but ultimately we need feedback, and I don't mean to say that it needs to be a formal process every time. Nor does it necessarily mean that you have to record a session and review it with a supervisee, but that feedback of, have you thought about this in context of your theoretical orientation, or even that care and regard, in demonstrating that provides feedback for how we need to actually behave or act or do in our sessions. So we absolutely love feedback. I think again, if you are working in an agency that's extremely busy, that you don't have a lot of time to provide individual supervision, or you're doing it just by default, there's a tendency to say, well, I haven't heard anything wrong or bad.
No news is good.
No news is good news, so you must be doing okay. But in actuality, I think that feedback loop is really important for counselor development.
Now, and this is perhaps a difficult question. I imagine, based on everything you've talked about before with respect to a supportive relationship, a growth-promoting relationship between supervisor and supervisee, not all feedback would be helpful, right?
Correct, absolutely. Have you tried? Not exactly helpful feedback, but how are you feeling, and how are you feeling, and how does that relate to how you're feeling in session? Absolutely important feedback. And I think what you've done really successfully in supervision is to incorporate the things that are happening outside of the clinic into the things that are happening inside of the clinic, and drawing my attention to ways that those experiences are impacting or not impacting my session. And so I think that's the type of feedback that's the really helpful stuff, is the pushes towards integration, not necessarily direct, oh, you used a paraphrase and you should have used a reflection of feeling there. I think that's the type of feedback that's the most helpful.
I think for me, as you're saying that, just to build off of that, that's why, and again, I hope this all comes across, a lot of my feedback is much more about process. Mm-hmm. So it may not be, you used a question and you should have used a reflection of meaning, but I might be paying attention to, in this session you used a lot more questions than you typically would. Mm-hmm. Or I think we had a session of yours where there were a lot of interpretive statements as opposed to, I guess, lower tier micro-counseling skills. And so it gave me the perception that you were driving for something, which led to us processing what was going on. Mm-hmm. So as you noted, it was less about, you did this, you should have done this, and more about what was going on in the moment. What were the overall themes I was taking away?
I noticed.
Right.
Help me understand. Walk this out for me. That's my favorite phrase that you use, is walk this out for me. Because it gives you an opportunity to, one, process it out loud, but two, to really consider, why was I driving that session? And how did it shift when I stopped driving that session? Because the session I know that you're talking about, that's exactly what happened. I knew I was driving it in that moment and then backed really far off and used basic micro-counseling skills and the basic listening sequence and got far further than we would have otherwise. But even to have that brought to my attention really forced me to take a look at it and go, yeah, why did I?
Well, now I'll just add,
Not
though,
forced. I shouldn't, that's the wrong word, but.
Well, no, I was going to say, while still trusting
that whatever it was fine.
Yeah, I think that's another thing. You mentioned bringing things from outside the counseling experience, things that might be happening in our personal lives. That's what I was referring to earlier as far as trust. I mean, I think by the time we reviewed that video, I think you had seen the client like 3 more times. I'm sure they were fine. I'm sure they were great sessions. Even if I notice something being off, even if I know that something is happening in a supervisee's personal life, that doesn't mean we have to pull the ripcord.
No.
That doesn't mean someone needs time off or a lecture. It could very well. But again, as part of trusting that the natural desire to care and to serve others is going to carry the clinicians I work with through their session, I think people can be forgiven if they used too many questions. If they used one that we talk about all the time, too many verbal encouragers, right? I love counting those up when I do a video review. Yeah, or the excessive head nods. But understanding that odds are the client is probably still getting helped. We've talked about this in class all the time. Clients don't notice that. They're not going to walk away going, I wish Jen would have used more feeling validations instead of interpretive reflection. They're not going to tune into that. So as the supervisor, I feel very confident that if I just point that out, you will probably adjust accordingly.
But that also requires you to look at the counseling lifespan and of my clients. And I think that's really a challenge for people who are in supervision or supervisory capacities to be able to go, they're new, and I'm going to trust the lifespan approach. Yeah. That it's going to look different from the beginning than it is to the end, and it's going to change and evolve. And some sessions are going to be great, and some sessions are going to walk away from and just go, I don't know, I don't know what I'm doing. So it requires that on your part to be able to understand and trust that counseling lifespan approach. But it also goes back to this whole counseling disposition. An emphasis on disposition rather than on skill. We've had this conversation before that the clinicians that we work with they have counseling dispositions that you want in caring relationships. Yes. They might not be they might not have certifications in 15 different things, but when it comes right down to it, they care. Yeah. They are empathic. They have unconditional positive regard for their clients, and they are able to engage in a way that is meaningful. And so it's those two things I think that's what's required from you. Mm-hmm.
Do you want to take us home with respect to our conclusions?
Sure. So a couple of key takeaways. One, effective supervision balances attention to clinician development, to client welfare, and relational factors of the supervisory process. That's the counselor disposition, and also the counseling lifespan approach that we've been talking about. There are many, many models of supervision. However, effective supervisors demonstrate care and regard for the supervisees and foster a supportive relationship with them that should mirror the therapeutic relationship that we want them to develop with their clients in the present and in the future. Effective supervision should emphasize process over outcomes, like we were just talking about. When feedback focuses on process rather than on particular outcomes or particular skill, the supervisee has an opportunity to incorporate that feedback more readily into what they're doing. And then supervisors in workplaces that emphasize evaluation rather than caring often lead to supervisees who are insecure, unsure, and relieved when the experience is over. I can't think of how many people that I've talked to in the past who have said, internship and supervision, I can't wait until that's over. And for me, it's actually been the exact opposite experience, which is why I'm grateful that we get to continue this supervision process for the next couple of years.
Me too. Thank you, everyone.
Thanks.